everybody knows this is really important, and I'm sure many of you have just seen how effective and powerful this is for these patients. So thank you for continuing to fight that fight and not giving up. And thanks to OpenBiome, Alex Koritz, AGA for getting behind this. There's a lot of really good people, which makes me not lose hope that we're not going to be able to do this for our patients. So my goal today is really to just spend maybe 15 to 20 minutes, help you all sort out how can you continue to offer FMT to treat these severe fulminant patients despite these gaps that have emerged that have made things more challenging and more difficult again. We're going to hopefully provide content that will help you with your own protocols so that you can be documenting things and doing things safely and as safe as possible for your patients, and also address questions that hospital administrators or IRBs may have about the status of the regulatory status around FMT. We will be at the end of the conference, at the end of the webinar, you'll get the slides, so you don't have to take notes. There's links on the slides to the current guidelines, and you'll also get an informed consent template that you can use. And I know OpenBiome is preparing some other things, as they said, that might help you more along the line later. So next slide here. Mike, great. This is just the disclaimer. Just out of legal trouble. Next slide. Okay, so this is what we're going to cover today. I'm going to just talk quickly about enforcement discretion guidance, the current status of things, talk about what the clinical guidelines, AGA and ACG say about FMT, recommendations around how to perform FMT in these patients, including donor screening, material processing. We'll kind of summarize things up and hopefully leave at least a good 10 minutes for questions. And I'm really hopeful that with so many experienced people in the audience, aside just putting questions up, really be interactive, throw up things that up there that you have done or things that you might think would be helpful to the other participants, and we'll try to shout those out and cover them as well. Next slide. So starting out, sorry, this is a review for many of you who've been doing this for a long time, but it's a question that always comes up, what does enforcement discretion mean and what does the current FDA guidance say? So easy way to remember it, enforcement discretion means you don't need an IND. No IND is required. This was the policy that was in place since about 2013 that enabled us to do FMT for all these cases of C. diff, both recurrent and severe that weren't responding to therapy. But in November 2022, they issued a guidance that ended enforcement discretion for FMT for material obtained from stool banks. This was because of the emergence of the two products, Faust and Rebiota, and FDA's perception that we didn't need enforcement discretion anymore because we had two products. And the way that they defined a stool bank was really sort of a centralized place where the donors are screened and then they distribute material. For purposes of definitions for their guidance, your own individual hospital laboratory, things that are internal, are not considered a stool bank under this guidance. So healthcare professionals may still prepare FMT in-house, use it to treat patients with C. diff infections of any sort, and do that under enforcement discretion without an IND. That is permissible. You're not breaking federal law. They do not want to disrupt patient care. The manpower is low, good or bad. It's nothing that your hospital has to be worried about if you decided to go ahead and do this. They're within federal regulations allowing you to do so. Next slide. So what do the two guidelines say? Well, we'll stick to GI guidelines since we're mostly a GI audience here, but the AGA recently published a systematic review and recommendations for use of fecal microbiota-based therapies. And this guideline recommends use of conventional FMT, so that's donor FMT from either stool banks or fresh-directed donors, in patients hospitalized with severe fulminant C. diff, not responding to antibiotics, based on, of course, very low certainty of evidence. The ACG guidelines also recommend FMT be considered in the same population, especially when the patients are poor surgical candidates. They made a strong recommendation here. The links to those two guidelines are there. So you are also well within treatment guidelines to be offering FMT to these patients. Next slide. So this just is a little review of the AGA paper and looking at any of the literature that we had to support FMT in severe fulminant cases. And it really is a highly effective therapy. It reduced risk of mortality. The number needed to treat to prevent one death when you were looking at FMT in the severe hospitalized patients was only 4. This translates to about 30 fewer deaths per 1,000 patients treated when you're talking about severe infections. And when you're talking about the sicker, more fulminant infections, I have 175 fewer deaths per 1,000 patients and 75 fewer colectomies. And there was not in this review an associated increased risk of SAEs in this population. Next slide. So before administration, this is just a little back to the FDA for 1 second. This is what they require. And if you kind of read through the full FDA guidance, that you're getting appropriate consent from your patient and stating in that consent that FDA considers FMT to be experimental, that you're doing some type of screening process under a licensed healthcare professional of the donor stool, and that there aren't big safety concerns around the product or how you're storing it. They're not very specific about, what that would be, but, they talk just sort of about improper handling, improper processes that I imagine most people, most hospitals wouldn't tolerate anyway. So next slide. So what should be in your informed consent? State specifically to the patients that FDA considers FMT investigational for this indication. Explain the risks and the benefits. So you can talk about, what we know in terms of data. Be very honest that we don't have randomized controls trials in these populations, but what we have shows that this is highly effective. Talk about alternatives, colectomy, loop ileostomy, other reasonable alternatives, ongoing antibiotic management, et cetera, and confirm that they understand what they're consenting to. A lot of these people are really, really sick in the hospital. So I imagine there's going to be proxy consent a lot of the time as well from family members. So just make sure that you're really documenting that these conversations have happened. And again, a template informed consent form, which you can modify, will be provided to you following the webinar. Next slide. As far as safety, we know that there's risks. Many of them are hypothetical based on, they're biologically plausible things such as infection transmissions. But we're talking about a much sicker population. So the risks here are potentially higher, certainly procedural related risks, such as, doing these endoscopically, complications of sedation, perforations, aspirations with upper GI routes of administration have been reported, particularly in patients really sick with an ileus who are lying flat in the ICU. Increased theoretical risks, I guess we talk about, haven't really panned out. We have limited long-term safety data, but talking about the stuff that we used to worry about more than a decade ago of changing someone's microbiome and putting them at risk of theoretical things in the future, I don't even really think should necessarily be something that we worry a whole lot about in this particular population when you're talking risks that are very small and theoretical versus great potential benefits. There is a systematic review and meta-analysis of over 5,000 patients that at least was reassuring, showing that the risk of sepsis or infection is quite low. In that analysis, it was 0.19%. If you want to give people a number, just say less than 1% chance of infection transmission. Then we specifically had FDA guidances around COVID, as you remember, STEC and EPEC infections, and then the notorious MDRO infection that happened. Again, those were very highly immunocompromised patients, people who had no neutrophils or were coming out of a stem cell transplant. In immunocompetent patients, these infections appear to be very, very small. Next slide. So in terms of protocols and how you do this, severe infection, white count greater than 15,000, bump in the creatinine, and the fulminant patients are those that are usually managed in an ICU, shock, ileus, megacolon. You want to really be timing the FMT as soon as you realize these patients aren't responding to standard of care antibiotics. The AGA guideline says 2 to 5 days, but really thinking about this upfront as the patients are rolling into the hospital. Is this somebody that we might need to be doing an FMT in, just to avoid unnecessary delays in treatment? It's not advised, obviously, if someone has a bowel perforation, an obstruction, and you want to really have more of a conversation in patients who are very severely immunocompromised, such as someone maybe going through chemotherapy or neutropenic and so forth. We usually do ours, and most people do by the Fisher protocol, which is repeat FMTs. We do recommend at least the first dose be given by lower endoscopy. This is to both confirm the diagnosis. You'll usually see tons of pseudomembranes, but we've also had things that were billed to us as fulminant C. diff that were not. So I've had like a severe CMV colitis and some other things that, the patient ended up not really needing the FMT. So you want to kind of get in there very carefully, obviously, no air or CO2 or water immersion. You're not pushing through to the cecum. You just want to get kind of high enough up without a loop and without too much trouble where you can get some of the donor material to stay up there. We really caution against upper GI routes of administration due to aspiration risk. And then most people, myself included, I know Monica Fisher, continue vancomycin throughout this. It's not held around the FMT, which is counterintuitive. You think, why are you giving FMT and also giving an antibiotic at the same time? But the only way I kind of describe it is that the FMT, you have someone where the vanco's not working. They're getting sicker and sicker. You start doing the FMTs and then the vanco kicks in. It seems to work. It doesn't really impact the success of the FMT. And it's a little hard to stop vancomycin, which is, a standard of care for a really sick patient, just to justify that. So most of us will continue the vancomycin throughout and continue to administer FMT every 2 to 3 days. Just until you see the pseudomembranes resolve, the white count normalize, patient's bowels start to firm up. And then often we'll keep them on vancomycin through discharge and then follow up as an outpatient a few weeks later once they've recovered from everything and do a final FMT or VOWST or Rebiota or such as an outpatient to prevent late recurrence. Again, there's no evidence for use of the approved microbiota products, though, the VOWST or the Rebiota in this acute treatment setting, just to prevent recurrence later on. Next slide. So stool source options. Okay, so Rebiota, this would be, it is stool and it is in a form that could be delivered through the scope. There's a couple of concerns. Number one, it's not FDA approved for this indication, so it would be an off-label use. That would be something that you would have to explain in your informed consent. It can be quite expensive at $9,000 a dose, and you're talking 2 to 3 doses in these hospitalized patients. You might get pushback or just maybe not be able to use it. It could be up to, $27,000 to do a course of FMT. And I think another concern is there's a broad range on the package insert of the concentration of bacteria in Rebiota product, and that it is much, much lower than we have traditionally been using with the OpenBiome material in terms of the numbers of bacteria per ml. So we don't have a lot of data yet. I think there might be an abstract coming at AGA about use in these patients, but don't have those numbers for you. Second option, go back to old school, fresh stool, directed donors, as much screening as you can get to kind of do things safely and in a timely manner. Patients usually would have a family member, close friend. Recommend not using healthcare workers for various reasons, but I kind of would say, is there anyone you just say healthy, clean living, no recent antibiotics, and usually there's someone who volunteers, or often there's someone who volunteers. You'd be wanting to do sort of reasonable testing, and we'll get to that on the next slide. And obviously an informed consent about that use of that material, and that maybe risk of infection might be higher because of, the limits of the screening that you're able to do in that situation. I'm going to hold off discussing more about using material from the stool bank, as Julie covered that earlier, and things are still kind of in a point of flux around that. Donor screening, though, what you should be doing, I think at a minimum, and this is stuff that's easy, or mostly easy and quick. You get a viral hepatitis panel, syphilis, HIV, blood work on the donor, stool testing. Most of us have these extended GI pathogen panels, or pathogen panels like the BioFires, or things that your hospital can run pretty quickly, these PCRs that you might get, a range of pathogens back. I think, we have a narrow spectrum. It's about 5 bugs. We have another that's like, 10 or 15, but you'll get a lot of bacterial and viral pathogens that way. The C. diff, it's something we've always done. We've recommended testing donors for C. diff. We know there's some colonization. Does it really matter if you have someone who has a toxigenic strain of C. diff and they're having formed stool? It just kind of one of those things we've done. The problem is as you know, the testing isn't validated on solid specimens. The laboratory would often throw it away or not run it. So I don't know if I would make this a deal breaker, but it is, if you're able to do it, that's testing you should consider. Other things to consider, this just kind of goes back to some of the FDA recommendations earlier on around COVID. You could have someone do a nasal swab with a rapid kit. You could use it's, if you look online, the AABBDHQ, that's the donor questionnaire that they use at the blood bank. If you wanted to document some sort of donor eligibility, you might have them fill that out and file it, keep it on file somewhere. I have picked up people who were inappropriate donors based on this. And then the question of MDRO testing, this is difficult. Because some hospitals, it's easy. You could get VRE testing or MRSA testing. Other places, it's going to be much, much harder to do that. That's, something you can consider. I know in my former institution, some of this was a send out, so it really wasn't practical. But if you want to really say that, the FDA did put out a warning about MDROs and, depending on how risk averse you are, screening for MDROs in this setting as well. Next slide. So how do you mix it up? I pulled that picture out. That's back. Predates OpenBiome when I used to just do directed donor screening for everybody. And I used a bottle of saline. I dumped about half of it out. I would have the donor bring in poop in a Tupperware or a Cool Whip container. I'd have them do a dose of milk of magnesia the night before so that they'd be able to perform and deliver. And it would come in, it was kind of softer and easier to scoop in. I'd get a plastic spoon from the nurse's break room and just put it into the bottle, close it up and shake it really hard. And then I would either dump it into an emesis basin or something and draw it up into slip tips to administer through the scope. That's pretty cheap and easy. And I didn't need a blender. I never used a blender. That's if you want to be real basic. On the more advanced level, especially if you're considering opening up your own mini stool bank operation, you can get laboratory quality sieves to kind of keep this more, seeds and things out. You can get a blender. If you're going to be storing material, a little lab freezer, a -20 costs about $600 that you could keep your stool in. You'd have to mix glycerol in. And I think, again, this is something OpenBiome's prepared to potentially help with some, people setting up their own small institutional banks. And then some type of plastic containers that you could freeze the aliquots in and keep them. But, this would be more, again, if you're going to be banking and using material, not so much for your fresh directed donors. Next slide. So what do you got to do, I guess? I would check with your local IRBs to see if they want to have any say in any of this. I know it might differ by site. But, some IRBs might say, we consider this, sort of a research type operation, and they might want some kind of of a protocol submitted. Your hospital administration or infection control people might also need to be somebody that you talk to. I would advise that you all have a GI or endoscopy protocol. It doesn't have to be super detailed. It can be a page or two, like who are the patients, what is the donor screening, what are we going to do, how are we going to do it, and just have that. So, you're kind of spelling out what you're doing. It's something you can refer to. And then if you're kind of like most places, you have one or two people who've taken on all the FMT, but they're not on call every weekend, and they'll be, or, they might be away on vacation. If you want your colleagues to be able to offer these and have it not be you all the time, I think having a protocol spelled out with your endo unit is a good idea. As far as potential insurance coverage, this is just one hurdle we used to have with donor labs. AGA actually has this on their website. And if you just Google AGA FMT coding guidance, use of screening codes, ICD-10 codes that you can use for donors comes up. These are just a couple of examples of screening codes, that would potentially get that covered and at least enable the test to be run. Assuming the donor has some type of insurance, there may be co-pays to this. This is something you could discuss with the donors, but again, I can't see it being more than a couple of $100 and something that can be dealt with later. local stool banking options. I know I've talked to different sites. There was a site that used to have a healthy volunteer who would just donate at regular, they'd be screened at regular intervals, like monthly, and then donate when needed. They were using that for their inpatients. You might have, again, a local bank, a small freezer where you could keep an inventory for emergent cases, and that you can scale that up depending on, how many you anticipate you're going to be doing per year. If you're doing 10 or more FMTs a year, that might, for severe fulminant, that might be worth your while. Next slide. So in summary, enforcement discretion still in effect. You're still able to do these without an IND for locally produced FMT. We talked about the key elements, really using your judgment with the screening. These are very sick patients, high mortality, very small theoretical risks. I feel like ethically this is something that we should be offering with what we know about the efficacy of this, and that doing things in a way that would protect the patient, protect us medical legally, keep the hospital administrators happy. This can all be done with a little bit of will and minimal equipment, more resources to come, a lot of really good people working on this right now, and very grateful to all the, OpenBiome and for continuing to fight this fight for us. So we'll open it up to the Q&A or any comments. I know Mike was going to try to bring in a few people who could potentially also serve as panelists. But while he's doing that,
Colleen, we have one question about pediatrics. What are the
okay,
options
yeah.
for pediatrics?
So what are pediatric FMT options? Okay. So I guess this is talking about, both severe fulminant and recurrent. In any scenario, there is no product that is approved for pediatric use. I think like many things, many approved medications, they're tested in adults and only later kind of roll out and are used off-label, so to speak, for pediatric populations. I think the problem with Vowst is it's capsules. So if you're talking young kids, they might have, and they're not tiny, tiny capsules, they might have trouble swallowing those. I guess Rebiota administering that either by enema, as they recommend, or colonoscopically for recurrent infection in kids is something that could be done. But I know that is also something OpenBiome is working on in some of the conversations with FDA, and hopefully with the change of administration at FDA, they might be a little bit more open to opening up enforcement discretion back to use of conventional FMT in pediatric patients. There was just another kind of infection question, but oh, good. They brought up two special guests, Monica Fisher, Byron Vaughn, who both agreed to jump in. And I don't trying to manage the chat here. Welcome to Monica and Byron. Do you guys have any thoughts, things that I said that you do differently, or things that you want to reiterate, or kind of what are you guys doing right now?
I mean, I still have some leftover material, fortunately, from an ongoing study with University of Minnesota, but soon I will use that up, and then I will have to resort back to patient-directed donation, which we have been doing. So most of my endoscopy nurses are trained. They are not very happy to do it, but we certainly can do it. We have the protocol in place, we have the informed consent. So I guess that's what we're gonna do in the interim.
Yeah, we're fortunate enough to have an institutional stool bank here. And I think, there might be something that comes out of these changes, or more institutions deciding that the most cost-effective way to manage this problem is with having an institutional stool bank. Particularly for C. diff, where I think FMT is really very much a transplant model more than it is like a therapeutic drug. I think a donor-directed bank makes sense.
Now, do you guys have thoughts on like how expansive the donor testing needs to be in terms of pathogens? Because there's certainly things that it grows and grows. I think a couple of us were on a European guidance and they were testing for everything, and you really biologically probably cannot get H. pylori if you're delivering stool by a lower GI route. And there's parasites that have complicated life cycles where it's really impossible to give somebody that infection when given by the lower GI route. I don't think we have to be at a point where every germ, because it exists, we need to be testing for. What did you think of that list that I presented? Or even what do you think about testing the donors for C. diff if they're asymptomatic and having formed stool?
I mean, I would advocate to test the donor with the BioFire PCR panel, the GI pathogen panel. I mean, unfortunately, that runs about $2,500, right? But what the diagnostic codes you provided in the past, I have not had issues, so I would strongly suggest to at least run that, especially because we have the EPAC, history, which we cannot ignore, right? So I would certainly recommend that, and I would advocate the patient to pick a close family member who they trust, preferably child, or spouse who
And
they
I,
trust.
and I do think the multi-drug resistant organisms are something that should be screened for. I mean, we don't want to be spreading these drugs that could end up being colonized in people. So I think that would make sense. But I agree. I think at some point you have to acknowledge that these drugs, these bacteria are not necessarily always bad. Many of them are commensals in our colon and are really more opportunistic pathogens, even E. coli species. So we have to have, I think, some common sense and do reasonable screening, but realize that we are testing asymptomatic individuals for a reason.
Yeah. And because the MDRO question, just because I know it can be really, really hard for people to get that, just speaking from prior experience, try to pick, obviously don't use healthcare workers. They have higher rates of colonization, people who've recently had antibiotics, probably other people you wouldn't be using as donors anywhere, like someone who's been in long-term care or who's had a prolonged hospitalization. Those are the big risk factors for MDRO carriage. So if you can't get the MDRO testing, I think at the least you're not, trying to choose donors who are less likely to have them would be a not unreasonable answer to that. Yeah, what do you think? So C. diff testing, is that something you guys are both doing on donors as well?
I actually, I don't think we are doing C. diff testing on donors. It's formed stool, so we generally don't test C. diff on formed stool.
Yeah, yeah.
Yeah, but the BioFire has it, so it tests for 23 different organisms, and at least we want to rule out colonization, right?
Yeah.
And it's like up to 5% in the general population, asymptomatic individuals, and they at least the GI pathogen panel, will be still performed in form stool. You really have to fight for the two-step C. diff testing in every single laboratory to test form stool.
Yeah, I always argued that if they had C. diff, they were colonized, they're having formed stool, then there was something else in there that was good that you wanted that was keeping them colonized from being sick. So it would almost make them a better donor. So yeah, I mean, I think if it comes as part of the panel and you can get it without a big fight and chasing the stool down and begging the lab to do it, but if I can't get it, I don't think I'm going to let someone die over it.
Yeah, I think some of that colonized data came from non-toxigenic C. diff. So I think people colonize with non-toxigenic C. diff. They kind of combat the toxigenic C. diff, but it's interesting.
Oh, I saw questions come up just a sec in
Yeah.
the panel. Do we need to check for hepatitis HIV? Yeah, I think that's easy. You can do it. It's quick. I think it's reasonable. Does OpenBiome have any example protocols they have endorsed for creation of FMT product? I don't think yet, but that was something that I think, there were talks about. If you guys have suggestions, things that you think could help get you through some of these hurdles, and if a sample protocol would help, that's something I think people would be willing to work on. There was another question that went by asking about the concentration of
Yeah,
microbes.
it's in the answered section. Yep.
Oh,
I think Byron probably can answer that pretty
Yeah,
well.
can Byron answer that? Because he
Yeah,
knows.
Byron, the question was, does OpenBiome have any data they can share regarding the amount of fecal microbes contained in their former product, so your product? I have read in the AGA guidelines that Rebiota and VOWST contain less fecal microbes per dose, but I cannot find this referenced anywhere.
Yeah, so the product we make at the University of Minnesota is standardized to a bacterial cell count. And I think it's something on the order of 1 times 10 to the 11th or 12th, depending on exactly which product you're looking at. And I think that's important. I think if you're doing donor directed, where you're actually taking someone's stool and blending it, you are likely getting a lot of bacteria in there. But when you take commercial products and they take one donor stool and they're going to dilute it out, and I don't know that we necessarily know exactly how much bacteria is in those stool counts. We've done some internal work here at the University of Minnesota where we have tried using lower doses of bacteria and did find that at some point our recurrence rates started to go up. And so that's why we started really standardizing our product to a higher bacterial count.
There was another question that came up, and it's kind of interesting because I think it speaks to the evolution of our donor screening. It says before OpenBiome, the recommendation was for someone outside the patient's home. Now it's okay for a household member. Is that just because it's easier to find them, or is it less risky of a C. diff susceptible microbiome? Is that like less of a concern? And I think really when we started doing this, it was 16 years ago, and it was kind of making it up as we went along. I remember it was like, what are you doing? What are you doing? And then with time, obviously some data coming in about the different infections that had been transmitted, different FDA guidances have kind of changed things. I think it's just, I think I do worry a little bit, especially with some of the European guideline that we had worked on for donor screening, that we kind of painted ourselves into a corner with the amount of testing. It was, it was like 100 different organisms, which seemed a little excessive. But yeah, I think things just changed with time. Things kind of evolved. And I think that we got a lot more comfortable with the safety, because back when we started doing this, there was just very, very little out there. I mean, I remember our little case series of immunocompromised patients in FMT. And, the thing that spawned that was one of the infectious disease doctors telling me that we could not do this in a kidney transplant recipient or she'd get gram-negative sepsis and die. And she didn't. She got better. And so we kind of cast a net and started publishing these things. We've now got the data set from the FMT registry, the AGA registry. It's up over 1,000 patients now. And we really haven't found infection transmissions. I know OpenBiome published something a couple of years ago that was over 5,000 patients, a series where there were, they were the EPEC and the STEC infections were the big ones there. But I don't know. Do you guys have any thoughts on that? Like using specifically, if I think Monica had said use someone as close to a family, close family member is probably the best.
Yeah. I mean, patients trust them, right? I mean, they share the home, they share the bed in some cases. So,
Yeah, I think we haven't really seen infections, particularly with C. diff, and I think probably infections are more related to the host, and not necessarily the donor, the stool donor. So I think if you're severely immunocompromised, that's when maybe you can run into some issues. But in general, I mean, people with C. diff, the benefits far outweigh the risks, first of all. And so whatever the risk of infection is in C. diff, it is I think quite low, and I couldn't even quote you a number on it.
Monica, there's an earlier question that said, should donor-directed FMT only be done in the case of critical illness? What about people who can't afford VOWST or Rebiota?
oh, I mean, no, we absolutely should be able to offer it for patients who have recurrent C. diff and failed multiple antibiotic therapy and unable to afford whilst or Rebiota, right? And then, I mean, as you started the conversation, that we might be able to even apply for an individual IND. So hopefully in the future, that path will be easier and streamlined, and that would be an opportunity for everyone.
I'm seeing a question there about clarifying the severe fulminant refractory to standard treatment. using donor-directed FMT over off-label rebiota, and I absolutely would recommend that. I mean, first of all, rebiota is not studied in that space and is not indicated for that. And second, we know, I mean, from Monica's data, that patients need an average of 2.5 to 3 FMT administrations. And those need to be done colonoscopically, not via enema. At least the first one needs to be colonoscopically. So I think for a number of reasons, sort of the tried and true standard donor-directed FMT is what makes the most sense for severe fulminant.
And
Agree.
I agree the same. And we had, we had hoped that maybe, I know there was some talk initially with Ferring donating some doses of rebiota to registry sites so that could be explored, and that fell through. So I really think it's on rebiota to help us deliver that data. And, if they want to support a series or a center with their material and get that data out, then I might change my mind. But for now, I'm a little, based on my past experience, and, I really feel this being very safe and very effective using donor-directed stool. I see a couple things in here, like where people have asked for sharing institutional protocol, and I want to say yes, but the protocol that I had been sending out is somewhat old. It's a couple years old and kind of very unique to my former institution and some things that you didn't need. What I'd like to do, and I promise I will, over the next week or so, tailor it, make it a little easier and more straightforward and simplified. And then I can give it to OpenBiome to send out to all you guys who were registrants, and you can take it and modify it for your institution. And send that out. You get along with the consent, kind of a package. You get the informed consent form and everything. But I just need to fix it up before I send it out again.
And just as a reminder for folks who maybe weren't on the beginning of the call, OpenBiome we're committed to getting out Colleen's protocol, but we're also going to be working to develop a larger training program to help you set up an in-clinic stool banking program, a small one, but that you can have, and so that you can build up an inventory even for those emergency cases, because you all know you don't want to be trying to find a FMT when you've got somebody in with fulminant disease.
And I think we have time for one more question, because we promised we wouldn't keep people for the whole hour. And I know you have to jump off, Julie, but this does come up. Where do you prepare the donor-directed stool? It's very annoying because most of the time the hospital just, has a certain thing for poop, and poop goes in the garbage or poop goes in the toilet. Poop can be in patient rooms, but somehow when it's FMT poop, it's raises, concerns. What are you guys doing for your preparation location?
Endoscopy suite.
Mm-hmm.
I mean, I'm very fortunate. I have a room dedicated to fecal transplant. So
we have a dedicated bathroom for electing that got approved. It's a very strange bathroom, but it's only used for donating, and then we take it to a space that's dedicated to prepare it. But yeah, it takes a little work.
Yeah, I do it at the bedside in the room. I either do it in endoscopy right in the endo room or at the bedside. I put out a chucks. I put my little stuff there. I wrap it all and throw it into the garbage when I'm done. But I haven't. I think that's one thing you might have to push back a little bit when you get, an administrator or somebody who's has questions about it. But no, this question and answer is awesome. This is actually interesting. Something came up: rebiota and Vallister being heavily promoted for use in hospitalized patients, which is very good to know. And that's something I think that they should not be doing, because I don't think pharma is supposed to be encouraging off-label use of things. So if that's happening, that's good that maybe push back on that, and something that it's good that we all know. But I think we're gonna kind of have to end it there, right, Julie? I know you have to get off and I have to move on with my day, but totally thanks to everyone. Thanks, Monica and Byron, for jumping in. It made it more fun. Thanks, Julie and Mike, for hosting it, and AGA for sponsoring and kind of sponsoring. And we promise we'll get all those materials out to everybody. And any final thoughts, Julie?
No, I'm just so grateful for this community, because I just think of how many lives you all have saved over the years, and it's just let's keep doing that. But it might be a smaller channel, but we'll do everything we can. We're committed to that. So thanks,
Julie,
for being
for
there.
not giving up.
No.
Really
Yay.
appreciate that.
Right.
And yet she persisted. No.
Yes. Thank you. Thank you all so much.
Thank
Have a
you.
great weekend. Okay.
All right.
Yeah.
Thanks.
Thank
Take
you,
care.
guys.
Bye.